So, picking back up where we left off with the foam cells, as the atheroma matures, the next step is that smooth muscle from the media begins to proliferate and spread into the subendothelium. A hormone called angiotensin II is released from the foam cells. Angiotensin II is a critical hormone affecting blood pressure that is made in the kidney and in the vascular walls. Here, the hormone is acting in autocrine and paracrine fashion, while it behaves as an endocrine hormone when it is released through the entire body by the kidney. It has an effect on plaque development transition from the lipid stage to the complicated stages. So while in the first part of atherosclerosis, LDL plays a major role, in the later, more complicated part of atherosclerosis, angiotensin II plays a key role in driving the process. Angiotensin II turns on growth factors that are released from multiple cells, including the endothelial cells, monocytes, and smooth muscle cells, to start proliferating and produce matrix metalloproteinases that are essential to degrade matrix. These smooth muscle cells migrate from the media into the intima, and in order to do this, they have to digest matrix to produce a path of migration. So here we show the smooth muscle cells proliferating up from the media, and they surround this inflamed area. They kind of wall it off. They have fibroblast-like properties, so as they become established, they become fibrotic, and you start developing a fibrous scar, which is referred to as the cap of the plaque. The fibrous cap separates the blood from the underlying prothrombotic lipid core. Further morphologic features of plaque maturation include intimal calcification and death or necrosis of foam cells in the lipid core. As fibrosis starts occurring, calcium is attracted to these areas for reasons that are not clear, and we get calcium deposits. It is possible that the sharp edges of the calcium deposits may play a role in the process of plaque rupture. It turns out that these calcium deposits have clinical usefulness since they can be seen on a CT scan as a subclinical indicator of atherosclerosis, and the total coronary calcium score has been shown to predict clinical cardiovascular events better than standard risk factors. As the foam cells start to necrose and they expel their highly pro-inflammatory content into the subendothelial space, they release a protein called tissue factor that is very prothrombotic. This is a local mechanism for increased thrombotic tendency in the plaque. At the same time, the endothelium loses its antiplatelet properties, so platelets become activated and begin sticking to it, which contributes to thrombosis. So let's talk a little bit about the prothrombotic state. We've already mentioned increased platelet aggregation. Now let's talk about the fibrinolytic system. Plasminogen is under low-grade constant activation by many factors, and it forms plasmin. Plasmin degrades fibrin, which helps prevent clots, also known as thrombus formation. The system can be stopped by plasminogen activator inhibitor 1. This molecule is increased in people with coronary heart disease, diabetes, obesity, and dyslipidemia, leading to reduced fibrinolysis. It turns out that angiotensin II also increases plasminogen activator inhibitor, contributing to reduced fibrinolysis and therefore a prothrombotic state. The final set of factors that contribute to thrombosis in people with atherosclerosis is that the liver begins to increase synthesis of coagulation factors such as fibrinogen, factor VII, and tissue factor, which we mentioned before is locally produced. IL-6 has been found to play a role in ramping up this acute phase reaction. So, we are going to end off on a quick discussion on how an arterial occlusion occurs. When the lipid phase occurs and an atheroma starts forming, it pushes the arterial wall out in an attempt to keep the lumen normal. This outward remodeling of the artery wall allows the maturing atheroma to grow large without having too much of an effect on the vessel lumen. Thus, clinically significant lesions may not be visible on coronary angiography, but may be detected with intravascular ultrasounds or CT scans. The theory is if that fibrous cap made of smooth muscle isn't very thick, then the cap becomes vulnerable to the shearing forces from arterial blood flow. If the plaque ruptures or erodes, this allows a clot to form and eventually results in total occlusion or blockage of the vessel. So we can think of two types of developed plaques: vulnerable plaques with a thin fibrous cap and stable plaques with a thicker fibrous cap. So here we have it. We have gone through the process of atherosclerosis.